All right. You are listening to Neuroclarity, where neurology meets storytelling, one clinical puzzle at a time. I am your host, Honorary Victor, and I'm bringing to you deep clarity on fast-moving neurology topic. Today's episode is all about recognizing vascular patterns in stroke and transient ischemia, the red flags, the subtle hints, and the must-know management decisions. So whether you are on morning commute, you're rounding in the ED, or you're reviewing for the board, let's log these lessons from four stroke center cases that will level up your clinical reasoning. Our cases are derived from Ching and Cheng's comprehensive review of clinical neurology. We are currently in chapter 2. We've done questions 1 to 45, and right now we will be doing 46, 47, 48, and 49. That being said, let us start our first case. Number 46. Which of the following is incorrect regarding the ICA, that is the internal carotid artery? A. The cervical segment extends from the bifurcation to the carotid canal at the skull base and has no branches. B. The petrous segment is located in the petrous region of the temporal bone. C. The ophthalmic artery arises from the ophthalmic segment. D. The caverous segment runs within the caverous sinus. And E. The anterior choroidal artery arises from the petrous segment. What do you think? I think it's best for us to slow down and walk through the segments of the internal carotid. There are 7 segments starting from caudal to cranial. The first segment is the cervical segment and it runs from the bifurcation up the neck. It has no branches. The second segment is the petrous segment and it is located inside the temporal bone. It gives off 2 arteries or 2 branches, which include the Vidian artery and the carotico-tympanic branches. The third segment is called the lacerum segment and it crosses the foramen lacerum, but it does not give any brain branches. The fourth segment is the caverous segment and it is surrounded by venous sinuses and cranial nerves. It gives off meningeal branches. The fifth segment is the clinal segment and this is actually a transitional zone. The sixth segment is the ophthalmic segment and this is where the ophthalmic artery branches off. And the seventh segment is called the communicating or the supraclinoid segment, which gives off posterior communicating, anterior choroidal, and then bifurcates into the anterior cerebral artery and the middle cerebral artery. Now, if you go back to your option, let's try to eliminate based on what we've said. A. The cervical segment extends from the bifurcation to the carotid canal at the skull base and has no branches. So, like we said before, that's right. So, that's true. B. The petrous segment is located in the petrous region of the temporal bone. That is very true. C. The ophthalmic artery arises from the ophthalmic segment. That is also true. D. The caverous segment runs within the caverous sinus. That is true. And E. The anterior choroidal artery arises from the petrous segment. Now that is false. Now, remember what we said previously. We said for the petrous segment, this lies in the temporal bone, and we said it gives off 2 branches, the Vidian artery and the carotico-tympanic branches. And we said that there is another segment called the communicating or the supraclinoid segment, and that gives rise to the posterior communicating artery, the anterior choroidal, and then bifurcates into the anterior cerebral artery and the middle cerebral artery. So, option E is false. The anterior choroidal artery actually arises from the communicating or the supraclinoid segment. That being said, let's go on to our next case. Question 47. A 69-year-old woman with a history of right hemispheric stroke, hypertension, hyperlipidemia, and diabetes comes with recurrent symptoms of left side numbness. A carotid ultrasound scan is obtained to determine if endarterectomy is indicated. Which of the following is correct? A. A right carotid stenosis of more than 70% in this patient should be treated medically. B. A left carotid stenosis of less than 50% should be treated surgically. C. Surgical treatment is recommended if right carotid occlusion is detected. D. A right carotid stenosis of less than 50% will benefit from surgical treatment. And E. Endarterectomy for 50 to 69% symptomatic carotid stenosis is less beneficial in women as compared to men. What do we think? Before we answer this question, let us unpack the nuance behind carotid endarterectomy. According to the North American symptomatic carotid endarterectomy trial, in symptomatic patients like this one who had a right hemispheric stroke, the degree of stenosis matters. So, for symptomatic patients, if you have a stenosis of 70 to 99%, then carotid endarterectomy reduces stroke risk significantly. Now, if you have a stenosis of 50 to 69%, carotid endarterectomy may help, but its benefits depends on three things. One, the sex of the patient, with greater benefits in men than in women. Two, the nature of prior events, with patients who have had a stroke having much more benefit than patients who had a TIA, that is a transient ischemic attack. And three, the type of symptom, with patients who had a hemispheric symptom being greater than those who had just a retinal symptom. Next, for patients who are symptomatic and have a less than 50% stenosis, there is no benefit from surgery. Instead, medical treatment actually helps. And lastly, for patients who have complete occlusion, medical management is the go-to recommendation. Now, let us flip it. What if the left carotid showed the disease? Now, this will be symptomatic since our events were right-sided. And in asymptomatic patients, carotid endarterectomy might be considered if the stenosis is greater than 60%, but only in carefully selected cases, and the benefit is modest with high numbers needed to treat. A quick side note: we now have better medical therapy, including high potency statin, dual platelet therapy using clopidogrel and aspirin, and risk factor control. And this actually narrows the benefit gap between carotid endarterectomy and medicine. So back to our question. A right carotid stenosis of more than 70% in this patient should be treated medically. So that's false. We said a stenosis of more than 70% should be treated surgically if symptomatic. The next is a left carotid stenosis of less than 50% should be treated surgically. That's false. Anything less than 50%, what do? You do medical management. Surgical treatment is recommended if right carotid occlusion is detected. That's false. If there's an occlusion, just stick with medical management. Next, a right carotid stenosis of less than 50% will benefit from surgical treatment. That's false. We said less than 50% stenosis. What do? You do medical management. And lastly, an end atherectomy for 50 to 69% symptomatic carotid stenosis is less beneficial in women as compared to men. So that is true. The benefits are much more in men when compared with women. So option E is the answer. Next question. Question 48. A 61-year-old man with a history of diabetes, hyperlipidemia, and hypertension presents with left hemiparesis without speech problems. The symptoms resolve while you evaluate the patient. Which of the following is correct? A. The patient should be discharged and no further testing is necessary. B. The patient can be discharged with follow up in 3 months and treatment change is not necessary. C. Observation before thrombolysis is indicated prior to symptom resolution to determine if the patient has a TIA rather than a stroke. D. MRI is not required since the symptoms have resolved. And E. The risk of stroke is highest in the period immediately following and soon after a TIA. What do we think? As always, let us debug our question. So, we are told that we have a 61-year-old man with vascular risks, including diabetes, hypertension, and lipids, and he presents with left sided hemiparesis that resolves during evaluation. Now, this is classical for what is known as a TIA, a transient ischemic attack. Let's talk about that. TIA, aka transient ischemic attack, is a medical emergency. We define it as transient episode of neurologic dysfunction due to focal brain, spinal cord, or retinal ischemia without acute infarction or tissue injury. Now, the definition of TIA has actually moved from a time based approach to a tissue based approach. And a TIA typically lasts for less than an hour, but more often than not, it lasts for few minutes. It is a warning sign of an impending stroke, and the risk is highest in the first 48 hours following the transient ischemic attack. So, it's critical, it isn't benign, and it is often a preview, a neurologic thriller to a full blown stroke. The risk is front loaded, with 10 to 15% having a stroke within 3 months, and about 50% of those will occur within 48 hours. That is why audit evaluation is essential. You don't wait, you need to do the following. 1. Do an MRI with diffusion weighted imaging within 24 hours ideally. 2. Do a vascular imaging of both the extra and the intracranial arteries. Next, do a cardiac workup including a telemetry, a Holter monitoring, and an echo if needed. Lastly, do a blood workup and strong risk factor control. You need to treat TIA like a stroke in progress because during the acute phase, you really cannot distinguish between a minor stroke and a TIA based on symptoms alone. So, don't just watch and wait to confirm the diagnosis. If they are still symptomatic, you must assess for thrombolytics as if it were a stroke. Back to our question. The patient should be discharged and no further testing is necessary. So we all know that this is false. This is a medical emergency. You cannot discharge that patient. Next, the patient can be discharged with follow up in 3 months and treatment change is not necessary. So you actually need to do a full workup to find out exactly what's going on. You can't just discharge this patient without doing any changes. Next, observation before thrombolysis is indicated prior to symptom resolution to determine if the patient has a TIA rather than a stroke. Now, this is false. You don't just observe, you don't just wait. You need to do something. You need to test, you need to do your imaging. Next, MRI is not required since the symptoms have resolved. Now, this is false. Like we said, you need to do your test. You need to do an MRI ideally within 24 hours and make sure that a DWI sequence is in there. And lastly, the risk is actually highest within the first 48 hours of having a TIA. So, option E is the right answer. Question 49. A 60-year-old man presents with acute neurological deficits. The brain CT scan is shown in figure 2.13. Let us look at our brain CT. Okay. Which of the following is the most likely etiology? A. Amyloid angiopathy. B. Intracranial aneurysm. C. Anticoagulation. D. Hypertension. And E. Venous sinus thrombosis. Let us take a look at our CT again. What do we say? So, I like to first orient myself. We are looking at an axial CT at the level of the basal ganglia, and right in here I can see a hyperdensity located medial to the insula, just at the lentiform nucleus. In particular, it is at the putamen. This is a textbook example of hypertensive intracerebral hemorrhage, ICH. It's the most common etiology and it is responsible for about 75% of spontaneous intracerebral hemorrhage. The common site of the bleed includes 1. The putamen, which we have in our case, 2. The thalamus, 3. The pons, 4. The cerebellum, and 5. The periventricular deep white matter. What is the underlying pathophysiology? Did you say lipohyalinosis? If you said that, you are absolutely right. Lipohyalinosis of deep perforating arteries caused by long-standing high blood pressure plays a very huge role. These fragile vessels can rupture, especially during blood pressure spikes. What of the other options? Well, amyloid angiopathy causes lobar hemorrhages. It's usually more cortical and often recurrent and is seen in the elderly. And this is an example of an amyloid angiopathy. Take a look at the location of the bleed and have this burnt into your brain. The next option is anticoagulants. Anticoagulants can cause bleeds anywhere, but usually these bleeds are more diffuse and generally you see lobar hemorrhages with fluid levels. So for example, this is a classical example of an anticoagulant causing a bleed in the brain. The next is the venous sinus thrombosis, and this typically results in hemorrhagic infarct and not deep intracerebral hemorrhage. Now, this is an example of a venous sinus thrombosis. And lastly, aneurysms. Now, classically, this ruptures into the subarachnoid space and not in the deep parenchyma, and then you tend to see bleeds in this region, the Sylvian feature. So, back to our question, is it PC? The answer is hypertension, options D. That was long. I hope you're not sleeping. I doubt you are if you're still listening to me. Anyway, you've just sharpened your neural instinct on four high yield vascular cases. We've navigated the internal carotid artery anatomy, and we've learned how to recognize transient ischemic attack urgency and hypertensive hemorrhage patterns. These lessons could change how you manage your next ED call or your board questions. If you found value into this deep dive, help us grow by rating, liking, subscribing, and following us on Twitter at NeuroClarityP. Don't forget to also share this episode to a colleague who is chasing clarity. I remain Onowori Victor, and you've been listening to NeuroClarity. Until next time, stay curious, stay sharp, and above all, stay clear. Bye for now.